Thank you everyone for joining us at the Spaulding New England Regional Spinal Cord Injury Center Knowledge in Motion program. Welcome also to our webcast attendees from 34 states across the US and from countries such as Canada, Mexico, South Africa, and Greece. My name is David Estrada. I'm the program manager. And also on the panel is Dr. Ryan Solinsky, who is our physician scientist in the Department of Physical Medicine and Rehabilitation. And he'll join us toward the end of the presentation to facilitate the question and answer portion of the talk. And with that, I'm very delighted to have tonight's speaker, Dr. Todd Linsenmeyer, who will be speaking about neurogenic bladder after spinal cord injury. Dr. Linsenmeyer is from Kessler Rehabilitation Hospital in the Department of Urology for the past 31 years. He's also a professor in the Department of Surgery and research professor in the Department of Physical Medicine and Rehabilitation at Rutgers, New Jersey School of Medicine. He's board certified in urology and internationally known for his presentations, publications, and book chapters. He is a past president of the American Paraplegia Society and has served on the board of directors of the American Spinal Cord Injury Association and Association of Spinal Cord Injury Professionals. He is chairman of the Paralyzed Veterans of America, sponsored clinical practice guidelines for the management of autonomic dysreflexia and urological management of individuals with spinal cord injury, and co-chairman of a new guideline on autonomic dysreflexia and autonomic dysfunction. And without further ado, take it away, Dr. Linsenmeyer, and thanks very much for doing this.
Okay, well, thank you. And thank you, David, for that introduction. And so I've been certainly looking forward to having this chance to talk with everybody. And the title is going to be Neurogenic Bladder, Common Questions and Misconceptions. And I'm going to sort of have it mixed a little bit with some questions and some different things on anatomy. And so we'll all sort of, and then at the end, I look forward to your questions. As far as disclosures, I am a consultant with Dr. Harkiman's group on epidural stimulation studies. And today I'll be going over bladder function after spinal cord injury, autonomic dysreflexia, bladder testing, various types of bladder management, and urinary tract infections. So one of the questions that I get very frequently from people who come with their spinal cord injuries is to say, why do I have problems with my bladder since my spinal cord injury? And the bladder is actually made up. We have your bladder on the top, and then you can see the sphincter. And the sphincter is actually somewhat large. It actually, and sometimes it's even called the sphincter mechanism. But this is part of what we call the lower urinary tract. The brain actually plays a very important role in regulating the voiding. And what it does is that you'll see here that when the bladder is full and that a person is in a socially acceptable place, then the front part of the brain will send a signal over to the bladder and to the sphincter, and it tells the bladder to go ahead and to contract, and it tells the sphincter to relax. There's another part of the brain though, and that part of the brain is constantly sending signals at other times that say, don't squeeze. And these signals go down the spinal cord and they keep the bladder from having contractions. Well, after spinal cord injury, the signals from the brain really can't get down through the spinal cord to tell the bladder not to squeeze. So if the bladder doesn't squeeze, then what happens is, if the signals don't get through, the bladder then starts to squeeze on its own. And this squeezing is actually called involuntary bladder contractions. And there are a number of problems when the bladder starts to contract involuntarily. First of all, there's back pressure of the kidneys. There's a feeling a person may have that they have to void frequently, or they may have urinary incontinence, which is just uncontrolled urine leakage, or they may have autonomic dysreflexia, which is a sudden increase in blood pressure, and that's in people with injuries at T6 and above. And I'll be going over that in more detail. There's another important area, and this is called the pons. And the pons is just located below the brain and above the spinal cord. And this area actually controls the urinary sphincter. And what happens is that the pons is what tells the urinary sphincter to open and to stay relaxed when the bladder is actually contracting. So after spinal cord injury, what happens is these signals from the pons that say stay relaxed during voiding doesn't get through. So the sphincter doesn't open very well and it starts to have contractions. This actually has a term, and it's called detrusor sphincter dysenergia. And in this situation, the urine won't come out very well. You can have retention, or the urine stops and starts intermittently. And this can actually make a high pressure in the bladder so that there's back pressure in the kidneys. Also, you can get this blood pressure rise during the voiding, and this is called autonomic dysreflexia. There's a final place that can also get injured, and that's very low down in the spinal cord. And this very low region is what actually sends those signals to the bladder to squeeze and to relax. So if this area is damaged, the bladder becomes what we call underactive, and it won't have contractions. And then a person will either not be able to void at all, or sometimes starts to have what we call overflow incontinence. And that's kind of like a bucket that's kind of filling up to the top, and then it just sort of spills over. Another term that you will hear an awful lot is neurogenic bladder. Well, neurogenic bladder is actually a name that's given to a number of bladder problems in individuals who lack bladder control. And this is either due to brain, spinal cord, or nerve problems. And this actually is not a specific term because it can include anyone who has an overactive bladder, an underactive bladder, or even no bladder contractions at all if it's due to some type of a neurological problem. Now, another thing that changes is, and this is important for people with injuries above T6, is autonomic dysreflexia. And when I ask people about autonomic dysreflexia, they're often not sure exactly what it is. And this includes healthcare providers who really are not familiar with spinal cord injury. So one of the things that's really helpful is for you to be able to know about this so that when you do have a healthcare provider, you can be able to also talk a little bit about this as well. So autonomic dysreflexia is a sudden, uncontrolled rise in the systolic blood pressure. And our current definition is greater than 20 millimeters above your baseline blood pressure, which can occur with anyone with an injury at T6 and above. And this occurs when there's some sort of an uncomfortable or some kind of a painful stimulus. One thing that's also I wanted to bring out is that the normal systolic blood pressure in a person with a high level injury is usually between 90 and 110. So somebody, for instance, going in the emergency room with a blood pressure of 140 with significant dysreflexia, the ER may say, oh, your blood pressure is only 140. But this would be considered high. So this is something to be aware of. So what are some of the most common causes of dysreflexia? Well, the most common cause is the bladder. And that's the reason that I'm talking about it and going to be emphasizing this. And this can be either from the bladder getting overstretched, if the bladder is having contractions or the sphincter is contracting. Also the bowels, if a person's constipated or impacted. Even doing a bowel program can set off this dysreflexia for a short time. And finally, you can have any type of other noxious stimuli. Pressure sore, ingrown toenails, childbirth, or even they found that lactation and breastfeeding can do this. Well, I grew up in Hawaii, and in Hawaii, one of my favorite things to do was to go snorkeling at Hanauma Bay. And as you can see here, there's all these coral, beautiful places to go and explore. So I would love doing that. But every once in a while, a moray eel would suddenly pop its head out from the coral. And that is what would elicit a fight or flight response. Just so you know, in my case, it was a flight response. And what happened is that this is when your sympathetic nervous system kicks in. And what happens is that it's preparing the body for an action when there's some type of a stress or a threat. And the person's pupils will dilate, the heart rate increases, the heart starts to pump blood to our muscles and our brain so that we can run or get away quicker. And also the blood vessels get narrower and squeeze so that our blood pressure goes up. The blood in the intestines actually plays a very important role in this fight or flight response. And if you look at this picture, it's pretty amazing. Look at all of those blood vessels, and there's just such an incredible amount of blood in the intestines. And so this is what is used and what will squeeze and regulate the blood pressure during this fight and flight. And what happens during that fight and flight, when the signals are coming through, in this case, we'll say from the bladder area, it sends a signal to the intestinal blood vessels. And so the blood vessels all start to squeeze and they tighten to get the blood out of the intestines to where we need it in our muscles. And also the blood goes up to the brain as well. Well, what happens is we have another system, and that's the parasympathetic system, or the rest and digest system. And those signals then come from the higher up from the carotid blood vessel signal areas, and they tell send a signal down to the intestinal blood vessels that say the blood pressure is too high. Relax, and the heart rate often will decrease as well. So this occurs, and then you kind of have a situation where things are being balanced with the parasympathetic and intestinal blood vessels keeping things relaxed and keeping the blood pressure from going too high. And then you have the sympathetic system kicking in and making those blood pressures squeeze a little harder. So this all works out well so that our blood pressure doesn't go out of control, but it's good enough to do what's needed to do to get away from whatever the problem is. Well, when you have an injury at T6 and above, the signals that from the carotid vessels and areas can't send any of those signals down to the T7. And that T7 is the area where it's going to tell the intestinal blood vessels to relax. The blood pressure is too high. So what happens? The blood vessels keep squeezing and squeezing and squeezing as long as there's something that's uncomfortable going on. And as far as going in more into the management and evaluation and things, this is actually a guideline that just very recently came out, just last month. And this is a consumer guideline, the clinical practice guideline on evaluation and management of autonomic dysreflexia and autonomic dysfunctions. And this is something that it's a free download. You can get this from the link, and it has a lot of things in there, that flow charts and different things you can take to your healthcare providers also to look at as well. Another great resource is from Dr. Solinsky, who just recently gave a webinar on autonomic dysreflexia. And this is another great, his presentations also would be something very worthwhile looking at as well. So here's another question. Why do I have a risk of kidney damage with a neurogenic bladder? Well, the urinary tract's divided into two parts. The upper tracts, and that's the kidneys, and then we have a tube coming down, the ureters. And we have the lower tracts, and that's that bladder and sphincter. What happens is that the urine is kind of pumped down in boluses down through the ureters, down into the bladder, and it gets pumped down, and here it is, you can see going down, and it goes into these openings called the ureteral orifices. Well, this is a very important configuration, because what we have here is those ureters are actually sandwiched in between the surface layer of the bladder, the mucosa, and the muscle, which is below that. So this runs down in this area, and it's for a very important function. And that's so that if we push or cough or do something, that our full bladder doesn't have the urine just squirt right back up into our kidneys. And so it actually acts as a valve, and it pushes down, and it works really well. However, if you have a bladder that's overactive and constantly squeezing or constantly overfilled, and this valve effect is constantly working, and it's keeping the urine from coming down from the kidneys, and it blocks things, and so that's when you have a problem. This is actually a picture, and this is the ureteral orifice right next to the X, and you can see sort of a little raising up in this area, and that's where that is sort of being sandwiched between the mucosa of the bladder, the surface, and down below is the muscle layer. I tell sometimes people to sort of think of that ureter that we had is sort of like a garden hose, sending water down into the bladder. And what happens is that if you have a normal flow, everything's great. But if you put your finger on and make a high pressure, just like if the bladder squeezes really hard, then you put back pressure on that hose. So that's kind of the problem that goes on. So sort of the take-home message is that due to the configuration of the ureterovesical junction, that high pressures in the bladder can cause poor drainage and possible obstruction or blockage of the kidneys. So the goal after spinal cord injury is really to try to have a very quiet bladder. Next, I'd like to go a little bit into the urological evaluation. And with regards to that, again, we have the upper and the lower tracts. And so let's first start with the bladder and the sphincter, the lower tracts. Unfortunately, the bladder is a poor historian. It won't really tell you how full it is. It won't tell you how hard it's squeezing. You'll certainly know if urine's leaking out and you don't want it to, but there's a lot of things that bladder and that sphincter just can't tell you. So what we do is we can evaluate those pressures and see what's going on with urodynamics. And the urodynamics machine is, you can see here on the left, and on the other side is a very other important part of this, and this is a blood pressure monitor and cuff that's used at the same time. The catheter that's put in for this test is actually very small. I tell people it's about the size of a wet spaghetti noodle, and here's a piece of spaghetti noodle, and here's the size of the catheter, and that's compared to a pencil. So when this is in the bladder, even people who have good sensation really don't even feel this laying inside the bladder. What happens is that it goes into the bladder, and then it has two things. One little port, it's called, puts water into the bladder and fills the bladder up, and the other is checking the pressures. You can also measure the flow if a person's voiding. And in people who we think may be pushing or bearing down to go to the bathroom, we actually have another small catheter that's very similar that goes in the rectum, so we can see how hard the person's pushing and straining. And this is what a normal urodynamics looks like. The top is the urine flow, and it should be a nice steady flow that comes out. And there's sort of two parts. The bladder is it's sort of filling up. Everything should stay nice and quiet. And then when a person feels full and okay, now I have to go, and the person's told to void, that pons we talked about earlier sends a signal down, the sphincter will relax, the bladder will squeeze, and then you get a nice good flow and the urine comes out. And you don't have to be pushing at all. That's the green line here, it just should flow right out. Well, this is a picture of a person with an overactive bladder and these involuntary contractions. The bladder starts to fill up, but then all of a sudden it just starts to fire off. And whenever it's firing off, the sphincter then is trying to keep the person from voiding, and it starts to clamp down. And the urine flow, instead of being nice and smooth, is sort of stopping and starting, and has a very intermittent type of a stream. And so this is sort of a classic picture of a person with involuntary contractions and sphincter dyssynergia. And finally, you can get a situation of an underactive bladder where you can just fill that bladder right up. There's no squeezing, no nothing that's going on. Autonomic urodynamics is also an excellent way to determine if a patient develops dysreflexia. And the reason is that you can be taking the blood pressures during the time that you're doing the urodynamics. This was one study that we'd done many years ago, and we looked at people who had injuries at T6 and above, and 78% of them had dysreflexia. At that time, there really wasn't any good definition of what the blood pressure should be, so we used 140 systolic as the blood pressure, because that time was considered as hypertension. And we found that with that definition, that 43% of people had silent dysreflexia. And so what we did was we noticed that the blood pressures, if you see here, had been starting all out. The mean pressures were about 117, but during filling and during the contraction, it went up to 169 or almost 170 millimeters of mercury. So, and they would be talking and have no awareness that their blood pressure is going up. So this is why we decided to call this silent dysreflexia. Here's sort of a picture of what that would look like. You see here the blood pressure when we actually were filling up the bladder and first started to squeeze. It was 114 for the systolic pressure. Then when this dysenergic sphincter and the squeezing started really occurring, the blood pressure went up to 160, and it sort of stayed up there for a while. And then after the person had gone to the bathroom and voided, then the pressure of the bladder quit squeezing. And here you see the blood pressure now starting to fall down to 140, and it continued to drop down. So the take-home message is that a fairly large number of people with injuries at T6 and above do have silent dysreflexia. And therefore, it's important to make sure, if you do have that higher injury, that you do that somebody is monitoring the blood pressure. If they're doing something, working on an ingrown toenail or whatever they may be doing, even if you're not having any symptoms of dysreflexia. The next evaluation that's part of checking the bladder is cystoscopy. And what happens is that there's about 30% of people with indwelling catheters, and it seems to be the same 30%. So it's not random that just everybody has this, but that they have these stones that can form around the bladder. And around the catheter. And when you deflate the catheter balloon, and then you pull out the catheter, these little eggshells, we call them, sort of fall down and they stay in the bladder. And if they don't get removed, they just keep growing and getting bigger and bigger as more calcium and materials build up on this. So on the other picture you see, I'm reaching in, and these are called little alligator forceps, and I'm breaking this up and taking out the pieces of stone. Here's a person who does intermittent catheterization, and when I looked in this bladder, this is actually a calcified pubic hair. And so this is something that would need to come out so it didn't keep getting bigger and bigger. And this is someone who came in after and hadn't come in for a while. And these look like calcified little kidney beans, but when you look at it closely and was broken open, these were actually pubic hairs that were all calcified. And you can see, especially on this one, all these layers, sort of like a tree, you cut across and you can see all the layers, one after another, laying coats and coats of material on top of it. And this is a person who didn't come in for some time, and they had a very large stone. And so for those stones, you can't just reach in and break them up. You use something called electrohydraulic lithotripsy. And this is a probe that's set up against the stone. And then it sends out what's called a shock wave, and it hits the stone and breaks it up. And there it is firing off hitting that stone. And then it breaks up into these pieces that you can see like this. And then if a person didn't have a spinal cord injury and just voided on their own, they might just say, okay, we'll go home and void, get the rest out. But in a person who doesn't really void, what I do is make sure to get all the little pieces out. So here I am again with those alligator forceps, breaking and taking those last little pieces out. And then finding out this is sort of what a normal looking bladder looks like without any stones or anything else in it. This is actually a bladder that's called a trabeculated bladder. And this person's been having a lot of high pressure in their bladder for some time. And they've got this scar tissue. That's what this actually is. And it actually kind of makes like a basket weave. And it actually makes it hard for the bladder to be able to stretch as well as it should. And so the pressures can go up higher and faster with that. So this is something we try to also avoid. And if we find somebody who has some of that, we want to make sure to get them on enough medications to keep things nice and relaxed so nothing gets any worse. The final sort of test we usually do is either a cystogram, where you fill up the bladder and you take an x-ray to make sure that urine isn't squirting backwards up into the kidneys, or some places will actually do video fluoroscopy, and they have a fluoro unit set up with the urodynamics, and that can also be a way to look and see if anything's squirting back up into the kidneys. But just in this situation, it actually shows a radio image of the sphincter and the bladder squeezing as well. Now, the reason for doing this, I've just told you before, this normal ureteral orifice, you wouldn't really expect anything to go up into the bladder because you've got a nice valve effect that we've talked about before. So the higher the pressure, the harder it is for urine to go backwards. But what happens is that in the posterior ureteral orifice, it's located way back in the bladder wall, and it doesn't tunnel. It doesn't have its normal tunnel. So what happens in this case is that when the bladder has pressure, it just goes directly up into the bladder. And the reason this is important is because if somebody, for instance, does get a bladder infection, the infection can go right up to the kidneys, and that actually is what can cause fevers. So we have to be especially careful with this situation. And also constant high pressures can stretch the kidneys up very quickly and cause something called hydronephrosis. So we need to make very sure that the person's bladder is not having any high pressure in it. And this is a picture of a posterior ureteral orifice. The blue is where that opening should be. And you can see in the back there is where it's actually coming out. So there's no valve effect at all. And urine would just squirt right back up with anything that happens. So the next question, how are the kidneys checked? Well, one of the things, and what's used most of the time, is a renal ultrasound. And it'll show you if the kidneys are being stretched, and also it'll show you if there's stones. So this is something that's very helpful. Another thing we can do is if we are wondering about what the flow is and the strength of the kidneys, is we can do a renal scan. And what that involves is injecting, it's called a nucleotide, into the bloodstream, and the kidneys will pick it up, and you can see how fast it will pick up, so you know how well the kidneys are functioning. And then you can watch, and it shows the kidneys as it's going down and into the bladder. So you can get a really good idea of the function of the kidneys. So this is something that we use if we're concerned about the function. For example, if let's say that on that ultrasound, the kidney was very dilated and stretched, you want to know if there's a blockage or what's going on. So the next question, how often do you need to get a urological evaluation? Well, to be very honest, the studies are lacking as far as what the ideal timing is. But usually a lot of places will perform it on a yearly basis. And this is what we do as long as the person's doing well. And we actually did a study. We had 100 people come in, and these are sort of the results to see whether they needed something done or they didn't need anything at all done. And so this was kind of what the study was. And as you can see here, that no matter what type of voiding pattern management they had, about 40 to maybe 50% of people had some sort of an intervention. Now, this intervention wasn't some major type of thing that was needed. A lot of people, for example, maybe just decided to try to not take as much medication, or perhaps had a problem with, we found that they're starting to get autonomic dysreflexia much more than they did the year before, and it was due to their bowels. So we could monitor and do something with the bowels. But there are this urodynamics did find a number of different things that we had some minor fine tuning that was needed for individuals. We also looked at, well, how long would you need to do this for? And you can see even out 16 years that people were needing different interventions. Now, one sort of, I think, a good and positive thing is, we usually think about, or you often are told, I'm sure, that, well, after the first, year or two or so, you really probably aren't going to have much change in your function or, anything. Well, this actually shows you that that's not true, that there continues to be many changes that continue to go on for years after your injury. So it's a continual improvement in it, or a continual change over time. So now I'd like to switch over and we'll talk about bladder management. And the first thing I want to say is that there are many types of bladder management. The next thing is that there's no perfect management that's best for everyone. There can be both advantages and disadvantages for whatever type of management that you pick. For the urological goals, therefore, we mainly want to have a management that will preserve the person's kidneys and their upper tracts. We want to decrease or prevent complications of the lower tracts. But the most important thing of all is to have a realistic management program that will allow you to have maximum independence that will best fit into your lifestyle. These are the many different types of bladder management that are used. And these are the most common ones, with the intermittent catheterization really being the gold standard that we try to have as many people as we can using. And I'd like to not go over the pros and cons of each of these for time limit as well as everything else. But you can read in this guideline here that we have from the Paralyzed Veterans of America. We'll actually go through the reasons for and the reasons against each of these different managements that I just showed you. And so this is something that I would recommend that you get. And just so you know, Jenny and I talked a little bit ago, and these links, don't worry about writing them right down. She'll be sending these out to you so you can get these at a later time when she sends things to you. So what I'd like to do instead is just talk about a couple misconceptions of a few of the most common types of bladder management. So the first will be this intermittent catheterization. And there are really two types of intermittent catheters. One that's sort of contained in a bag and it's a sort of a sterile and you pass it out into the bladder. And the other is sort of a clean intermittent catheter that's used, single use, and it's thrown away just as the other one is, but it doesn't have an attached bag to it. So now I am going to ask you some questions, and I'd like you to answer just true or false to yourself, and then I'll sort of go over some of the answers. So first, if you're having problems trying to pass a catheter into the bladder, it's best to try a larger diameter catheter. True or false? The answer is true. Those with spinal cord injury often have a non-relaxing sphincter. Remember, we talked about detrusor sphincter dyssynergia. So trying to pass a smaller catheter, in this case, this is a 12 French catheter. Underneath, it's a 14 French. But this very small catheter will actually just sort of bend on itself rather than being able to pass into the bladder. So one of the things, and this is something a lot of people do have trouble passing the catheter, is one of the tricks is to pass the catheter up to the sphincter. And when you feel that tightness and resistance, you just hold it in place. And usually after about 20 or 30 seconds, the sphincter, it's clamping down really hard because it doesn't want anything to go in, but it'll just start to relax, and then you can slide it the rest of the way in. There are also medications that can be given if it keeps being a problem all the time that you can be prescribed. Tamsulosin or Flomax is what we use a lot and works really well. And it can be used for men or for women with a real tight sphincter. Lidocaine jelly can be instilled into the urethra and get up to that sphincter area, but that's more used for an emergency if that sphincter is really tight, and not usually used just as a routine, everyday kind of thing. And a final thing, if you're really having a problem, can be digital stimulation. Now, of course, if somebody's having severe autonomic dysreflexia, you would need to have medications and things on board too, so that the blood pressure didn't shoot up really high. But by doing digital stim, it relaxes the anal sphincter, and that, when it relaxes, sends a signal up to the urethral sphincter, and it relaxes. And I remember I had one occasion in the emergency room where everything was being tried. It was almost being considered to send the person up to the as an emergency surgery to put in a suprapubic catheter to drain the bladder. And I did the digital stimulation, and the sphincter relaxed, and then the catheter passed right into the bladder. So that's something else to remember. Now, there are some preventative things that can be done to try to prevent this sphincter spasticity. And one of them is not letting the bladder get over distended, because whenever the bladder is getting stretched up, the sphincter is trying to grab and get tighter and tighter to keep the urine from coming out. Another thing is to avoid constipation, since the rectal sphincter will also tighten when somebody's really constipated, and it sends a signal up to the urinary sphincter to tighten. So these are two things that can be helpful also. So now we get to our next question. So true or false? Letting the bladder get overstretched will strengthen the bladder. Sort of the idea that you all have heard, no pain, no gain. So true or false? The answer is actually false. The bladder is not really a muscle. Think of it more like a balloon. And when you blow up a balloon, and if you really, especially if you filled the balloon and stretched and sat for a while, and then you let everything out of it, the balloon would be really flabby. It wouldn't be stronger. And the same is true with the person if they're purposely trying to let their bladder get bigger and bigger to get it stronger. So now I want to switch over to another method of management, and this is indwelling catheters. There's the two kinds. There's the urethral catheter, and that's the one that passes through the urethra into the bladder. And you have the suprapubic catheter, and for this one, a small surgery is made. It's sort of below the the belt line, where the pubic hair is down in the lower part. And this catheter then is put in place, and then it develops a tract so that the balloon can be deflated. It can then slide in and out. Sort of like, for instance, a person with a pierced ear, there's always a constant tract there, so it's really easy to just slide it back and forth. So with that being said, true or false? Suprapubic catheters need to be changed by a well-trained professional. And the answer is false. The reason that this question is asked is because there are a number of hospitals and people who say only the urologist can change a suprapubic catheter, or somebody who's very well trained and skilled with catheterization. And that's because what happens is that when you pass a catheter suprapubically, notice that if it keeps going and going and going in, it'll slide right up in the urethra in backwards direction. And then you can imagine when you blow the balloon up, because this is deflated right when it's getting slid in, and then you inflate the balloon, it can cause terrible bleeding. If a person had a higher injury, dysreflexia, can cause high fever, it can cause all kinds of problems. So if this happens once or twice, people will never again want to have just anybody kind of do it. But this is the trick. And I will say that when I give talks sometimes, like a morning rounds to a urology department or something, everybody's kind of sitting there listening and being, interested in what I'm saying, and drinking their coffee and eating their bagels. And then I get to this slide and I start to talk about it, and everybody puts their coffee cups down and their bagels down, and they start oohing and awing about this. So this is something that's good for you to know, because a lot of people don't know about this. But all you do is that you put a little piece of tape right at the skin line of the catheter that you're going to remove. You deflate the balloon, and then you have the distance, so you know exactly how far in. You pull this out, you grab the next one exactly the same place, and it'll slide right into that point. You blow up the balloon, and it'll be in just the right place every time, and there won't be any danger and problem with doing that. And this type of catheterization is actually safer change than trying to slide a catheter up through somebody's urethra and up into the bladder. And this is just a picture here. You see where the tape is, and then you have the catheter. Now, one thing to notice is that when a catheter has been in the bladder for a while, it sort of becomes a little discolored. So if you pull it out and you go, oh no, I forgot the tape, don't worry, because if you look, you'll just sort of be able to see the difference right here and here. So as long as you slide it in to where the discoloration changes, you'll still be in that same place. Now, the other problem I sort of alluded to is the problem with the urethral catheter. And that's passed down, and the person won't go any farther. Okay, well, I guess it must be in the bladder because it won't go any further. But really what it is just hung up where that tight sphincter is in a younger person, or in an older, especially male, it may be from their prostate enlargement. But for whatever reason, the balloon gets blown up, and then you can imagine the same problems with the bleeding, the dysreflexia, the sepsis, and all that going on. So unlike the other one that you have to be careful not getting it in too far, it's very important with these type of catheters, they're going in the urethra, that you pass it all the way up to the Y connection, or the hub of that catheter. Once it's in there, then you can inflate the balloon. And then if you want to, you can gently pull it down a little bit, because by putting it all the way up to the hub with the tip of the penis, you'll be, it'll be more in there than would otherwise need to be in there. So it just slides back out. In a woman, you might not have pushed it in quite as far, but you still want to go in a fair amount, or you can, if you want to, even go up to the hub. So in summary, for catheter changes, Always mark the depth of an old suprapubic catheter before changing it to a new one. And always pass a catheter, if it's a urethral catheter, to the Y connection before blowing up the balloon. So now we'll go to reflex voiding. And reflex voiding is where an external condom catheter is usually put on for the men. And then they have a drainage bag and a collecting tubing that's sort of connects these two together. And for women, there are some women who do reflexly void, and what they usually do is just wear some sort of a pad that they will change frequently when their bladder fires and they void. But not a lot of women will do that, and we don't really have a good device to collect the urine for women. So, true or false? The newer adhesives have eliminated the risk of external collecting devices from coming off. True or false? The answer is false. Unfortunately, there's a number of issues that can make these external condoms come off no matter how good the adhesive is. One of the most common issues is on the top. And what happens is if that tubing gets kinked and twisted a little bit, going down into the leg bag, and then the bladder squeezes, the urine goes shooting out with good force, and then it sort of fills up at the tip of this area and sort of loosens and almost blows it off, but not quite. And then on the second squeeze, then it usually blows it off completely, and the person can get very wet in the front of their clothing and be very embarrassing. So this is something that people really don't like to happen at all. Another problem can be that if the urine leg bag gets too full, one thing, it could be sort of pulling and tugging on this external condom. That usually doesn't make it come off, but it's so full that nothing more will go into it. So it's almost like you pinched off right at the entrance. And again, the external condom will fill up and just blow right off. And lastly, if somebody's using some sort of a body lotion or something and you gets a little bit of that on the penis, it really doesn't allow the adhesive to stick very well. So again, it will fall off. So the next thing is called bladder expression or Crede or Valsalva voiding. And Crede voiding means you just sort of are bending over and pushing on your bladder to get the urine to come out. And Valsalva voiding is where you're actually really pushing and straining to get the urine to come out. So, true or false? Bearing down to push the urine out will help to teach your bladder to actually start to work again. And the answer is false. There's something called the guarding reflex. And what happens is that when the sphincter feels pressure in the bladder, it will automatically clamp down and try to keep the urine from coming out. And that's a good thing if you're, coughing or lifting something heavy or doing something, but otherwise it's not good. And it's kind of the same idea, to be honest, as being this detrusor sphincter dysynergia when the bladder starts to squeeze and the sphincter grabs. But the problem, because of this guarding reflex, is when somebody's trying to push the urine out, look at the lower one, the green, the abdominal, the person's pushing and straining. It's going up and down and up and down. And here's the pressures in the bladder trying the hardest to get the urine out. And if you look at the urine flow, there's nothing. Even with all this pushing, nothing went on. Eventually, often people do get some of the urine to come out, especially as the bladder gets really full. But there's a number of concerns with constantly doing that. One is either getting hemorrhoids, or if you have some hemorrhoids, making them worse. You can also have hernias occur. And in men, for instance, who have prostate blockage, they're constantly pushing to try to push through their prostate, urinate with a blocked prostate. They'll often get a hernia. And then I was just reading, there's something called the Valsalva maneuver in weightlifting. And it's actually used, and it's, they said, important for a lot of people. as they're lifting very heavy weights, you take a very deep breath and hold it. And that helps to support the spine and everything with this high pressure in the abdomen from where you are holding all that air. And but at the end of this article, it said the downside of Valsalva maneuver, specifically a sharp spike in the blood pressure, isn't so good for everyone and may be associated with cardiovascular problems, stroke, aneurysm, blindness, and other concerns. Well, I will say that I've not had anybody that I'm aware of who's had these issues, but I am concerned with some, particularly an older person and their cardiovascular and the system when they're having to push and strain so hard. So these are something to be aware of. So in our guideline that I showed you before, this consortium guideline, we recommended to consider the use of Credean Valsalva voider for individuals with lower motor injuries and those with who have outlet resistance that's very low, in fact, a weak sphincter, and following a sphincterotomy. But to consider avoiding this type of maneuver if as the primary method, to not just have everybody doing that. This is a woman who you can see here. She has a very weak sphincter. It's almost not closing at all. And you can imagine that just a little bit of pushing and that urine is going to come flowing right out. So this might work well for her. So in summary, there are risks of upper and lower tract complications following spinal cord injury, but careful evaluation and management will significantly decrease these complications. And so the final topic that I wanted to talk about was urinary tract infections. And why did I pick this? It's because it's really the most common problem following spinal cord injury. And it's actually one of the most common reasons for people having to go to the hospital if they get severe bladder infections or kidney infections. So, true or false? It's helpful to have bacteria colonized in the bladder. Well, this is actually a trick question because bacteria can actually be a friend or a foe. With regards to a study on a skin article that was written, it said, a new hypothesis is that bacteria on the skin directly benefit the person and are rarely harmful. Staphylococcus epidermidis, which is 90% of the bacteria on the skin, was found to actually disrupt the signaling of competing bacteria, such as ones we don't like called Staph aureus, and ultimately leads to inhibition of the colonization of these competing bacteria. We also have another type of bacteria called Pseudomonas, and we all know that, and we don't really like to have people with Pseudomonas. But what's interesting is that the byproduct of Pseudomonas is actually marketed, and it's a very effective type of ointment because it's a very effective topical antibiotic that's used to kill Staph aureus and streptococcal pathogens. It also suppresses fungal growth. So you can see that this type of bacteria can be a friend in those situations. One of the recent articles has actually noted that the urinary tract is inhabited by a unique urinary microbiome that is felt to have a role in maintaining urinary health. And a microbiome is actually considered a group of bacteria that are all living together. But remember I said about being a foe? Well, in these microbiomes, there can be some microbiomes can just have urease producing organisms. And these Proteus is probably one of the most common ones. And with that type of organism in the bladder, there is an increased risk of having bladder stones or even kidney stones. So that's something to be aware of. So next, those with neurogenic bladders and 10 to the 5th colony-forming units of bacteria in their urine should be treated even if they don't have any symptoms. And 10 to the fifth is considered to be a fairly high number of bacteria. And the answer is false. It's a common misconception that bacteria counts of 10 to the fifth means there's an infection. And in able-bodied people, that's usually the case. And it should be treated in those with spinal cord injury, even if there's no symptoms. But an understanding of bacterial colonization versus a symptomatic infection where you get tissue invasion and redness and symptoms is the key to when to treat or not to treat bacteria. And so these are two expert panel groups. Both have the same criteria that they define as a symptomatic infection. You have to have three things. First, increased bacteria in the urine, which is obviously a given. Next is increased white blood cells, but you can get that just from passing a catheter in and out. But the third and the most important one is the new onset of symptoms. And basically, the most common symptom that is almost always there for a true infection is you'll have cloudy urine with an odor. And there can be other things that an able-bodied person may complain of, as pain over the bladder or painful urination, or it can be something more unique for a person with spinal cord injury, such as autonomic dysreflexia. So there are good reasons not to treat asymptomatic bacteria. If you treat them, you can disrupt that bladder microbiome, the friends, and do more harm. The other thing is that there can be some potential side effects from the antibiotics, such as allergic reactions or C. difficile. So it's extremely important not to disrupt the person's microbiome unless there's a symptomatic infection. Sort of a nice analogy I like to think of is like with a very well-groomed yard. If that grass is growing real thick and very well, you're not going to really see any weeds or anything in it. But if the grass has a lot of drought and has a lot of problems and isn't well taken care of, for instance, a bladder that's getting one antibiotic after another and knocks out all the good bacteria, well then in this case where you see in the yard you have these weeds and clover sort of growing up in there. So that's kind of the situation that can occur. But in medicine, we never say never and we never say always. So again, there are exceptions, and the one that I've talked about before was that urease producing bacteria. So even if you don't have any symptoms and you have something that might create bladder or kidney stones, what we usually do is first make sure there's no stones, and if there are, get rid of them. And then we give antibiotics, and we usually use it, give them 1 or 2 courses trying to knock it out. But if it doesn't knock it out and they're not getting stones, then we don't do anything. We just consider, okay, well, that's their microbiome. And I've had people for years and years and do fine with it. So true or false? You do not need to get a post-UTI urine culture and sensitivity after being treated and after you've have been getting better for a symptomatic UTI. And the answer for that is actually true. A very common misconception is that you should get a post-UTI urine culture and sensitivity to make sure the infection is resolved. However, in obtaining a routine urine culture on asymptomatic people, what it will do, you'll always have a positive urine because of the colonization, and then that often leads to a person getting more and more antibiotics. And here's an example of that. This is a 54-year-old woman who had a T10 paraplegia. She came to Kessler for her annual evaluation, and I noticed she had a PICC line for IV in. And I asked her about it, and she said, well, my PCP found an infection in my urine. And even after several courses of different antibiotics, he couldn't get rid of the infection. So he referred me to an infectious disease doctor who is now giving me 4 to 6 weeks of IV antibiotics. So I asked her, I said, well, have you been having any symptoms of an infection? And she said, no, they just keep finding an infection in my urine. So unfortunately, overtreating asymptomatic bacterial colonization is something that I do see quite frequently. So true or false? Individuals are usually accurate in knowing when they have an infection. The answer is actually false. This was a study we did where we had people coming in and they were sure they had a bladder infection, and we looked at the criteria and what was going on. And about 60% of the time they were right, they did have an infection. But 40% of the time they did not. And often the spasms or whatever were going, spasticity, the most common second thing seemed to be that they were having some impaction or some issue with their stool, but there could be other problems as well. And this is sort of an example of that. This is a 48-year-old man with a T6 paraplegia who called from home. He was complaining of a high fever from his UTI, and he reported he just felt too sick to come in. And could I just call in some Cipros? Well, I told him that it was important to come in for an evaluation. And now what we would do is also give the option for a video telemedicine call. A little later, he called from the parking lot and he said he just felt too sick to come in. Could we just come out to the car and get the urine sample? Well, we went to his car. He had a temperature of 102, tachycardia, his heart was beating very fast. He had profuse sweating. And he did not have an injury above T6, so we knew he wasn't having dysreflexia. So we called 911 and he was taken by ambulance to an acute care hospital. He had an evaluation and then emergency surgery because he had acute appendicitis, but fortunately it hadn't ruptured. Another thing to note is that fever is actually a very rare symptom of a UTI. It can occur with a kidney if it gets up to the kidneys. So it is important to rule out other causes of a person's complaint of having a UTI. In fact, nowadays we have to think about COVID rather than just assuming and treating that a person has a UTI. And the thing is that when somebody goes to ER, first thing you do is get a urine. If you dipstick the urine, it's going to show that it's positive. But that doesn't mean that that's the reason that that person's having a fever. So true or false? Frequent catheterizations will introduce bacteria in the bladder and increase the risk of bladder infections. The answer to that is false. Frequent catheterization actually decreases the risk of bladder infections, and those who catheterize every 4 hours have less infections than those who catheterize every 6 hours. This is a person, Dr. Lapidus, who actually is the one who first popularized doing clean intermittent catheterization. And he wrote that the blood flow to the bladder can be reduced by increased bladder pressure or by distension of the bladder. And when you have this slower blood flow, it lowers the normal defenses in the bladder wall. So then it allows invasion of the normal colonized bladder bacteria, and that can start an infection. So avoiding these high pressures in the bladder and overdistension is the key to preventing a urinary tract infection. Another thing that can happen if the bladder really gets stretched is it can actually tear and make some small mucosal tears. And here's shown looking down at a suprapubic catheter. And you can imagine how the bacteria can just get right into those little tears and start up an infection. So here's my motto that I always use. And my nurses and everybody knows this very well. When in doubt, cath it out. And so that's something that is an important thing to remember. So next, true or false? A Foley or urethral catheter has a higher rate of infection than a suprapubic catheter. The answer is true. This was a study, and it's rare to do prospective and not just looking over old records, but people one after another coming in for 3 years. They looked at how many infections they were getting and what kind of management. And they found people with indwelling catheters had 2.7 infections, it says per patient day, but mainly look at the number, 2.7. With people with intermittent cath, it was much better. It was only 0.4. And with suprapubic catheters, it was even better than that, 0.3. So this study actually found that suprapubic catheters had less infections than any other method of management. But other studies have shown that it's about equal to what we consider the gold standard of, and that's the intermittent catheterization. So why do people have less infections than other methods if they have a suprapubic? We don't know for sure, but my thought is that the suprapubic has a larger diameter. We use a 24 French catheter. It's a pretty good size. And it's less likely, therefore, to get kinked. So the urine can just keep traveling right up over the top of the abdomen and the front of the surface of the leg and go right to the drainage bag. And that's the reason for less infection. A common misconception is that the indwelling urethral catheters are the same as suprapubic catheters. They're all kind of sometimes lumped together. But in reality, urethral catheters are not the same as suprapubic catheters, and urethral catheters have at least twice the risk. Now, that doesn't mean that you can't use the urethral catheters. It just means you have to make sure that if you have one, that you don't let that leg bag get too full, so that you allow good drainage. You make sure the catheter is not getting kinked. And we have a large number of people that use these and do very well and like them very much. So in summary, there are many differences. There is a difference between bacteria in the urine and a symptomatic infection. You want to treat a symptomatic UTI. If a person has a fever, look for other causes and don't just assume that it's a urinary tract infection. And to prevent urinary tract infections, it's really important to try to keep the bladder from getting overdistended. So I've left the last question that I get asked probably the most to last. And that is, will my bladder ever work normally again? Well, there are a couple points to bring up. First is the effect of the spinal cord injury is different for everyone. The next is, from our annual evaluations, we now know that the nerves keep changing even after many years of having a spinal cord injury. So it's not like, okay, it's been a year, nothing's going to change. But what's also really exciting is that there's a lot of new modalities, such as epidural stimulation. They're showing really good promise to helping to restore bladder and sphincter function. So at the current time, the goal is to keep your kidneys and your bladder as healthy as possible, and this is to allow you to have as much independence as possible as your body is having its own recovery, and as new scientific breakthroughs are helping to get your bladder to function as close as possible to normal. So I have just a final couple thoughts. And bladder management is a major part of a person's post-spinal cord life. However, a neurogenic bladder doesn't mean you have to restrict doing the things that you want to do. And I wanted to just show you a couple examples of a few of the people that I know and go through that. And this is one. This is a 71-year-old man who has a C6-7 incomplete tetraplegia, and he's very adventurous, and here he is in Colorado skiing down on a wheelchair type of adapted equipment and just having a great time. This is a person who was on the rugby team in medical school and suffered a C6 spinal cord injury, and had been doing really well and great in school, and here he was with this injury. one of the things that he really missed a lot when he first came home was going to be able to throw and play catch with his dog, because they had a real connection. But he was able to find this device, and he has a great time being able to play with his dog. And he's also, by the way, went back and finished up his medical school, and he's now one of our SCI research directors. He also loves to drive this hand-controlled car. Says this feels a lot like just before he got injured as well. And this is the final person I'll just show you. And he has a C6-7 tetraplegia, and this was as a teenager. And when he got hurt, he was told early on, many years ago, you will never have children, and dating does not look so great. And later, when he was writing this all down, he said, those words fell upon me, crushing in a merciless way my hopes. Well, here he is with his wife during their wedding. And here he is with his new baby girl. So with that, I will end, and thank you for your attention. And now we can get to the questions section.
All right. Thank you, Dr. Linsenmeyer. That was a tour de force of everything that patients are coming in to talk about in a urologic sense. Over the course of the talk, people have been sending in a lot of questions, and I definitely appreciate that. I tried to organize them, and we'll try to get to as many as we can. Dr. Linsenmeyer, you have your work cut out for you. Some of these are pretty tricky. The first one is about medications. So since chronic anticholinergic medications are associated with adverse events, besides mirabegron, are there other medication options for those with a spastic bladder?
So the standard, and we actually did a survey right now, seems to still be using anticholinergic medication. And one of the biggest concerns certainly are the dry mouth and the constipation. And so there are different types of formulations. Some cause more dry mouth than others. So we often work with different doses and try different things. If that doesn't work, you can also, especially if you have a catheter, or if you do intermittent cath, you can actually dissolve the oxybutynin is the one that you can dissolve and instill right into the bladder. And that will work just exactly the same as if you take it by mouth. The biggest issue is sort of the hassle factor of doing it. But we'll tell people, well, if you're busy or something, just pop the pill and take it. And if not, use it the other way. The mirabegron is a great medication. It's not, I don't think, quite as strong as anticholinergic. So sometimes it's best to combine it so you can have a lower dose of one and the other. The biggest problem we have is that it's very expensive, and the insurance companies say no. So we just have a tough time with that. Botox is something that we also sometimes use if they're dry mouth, constipation. But we also can use another modality called percutaneous tibial nerve stimulation, which is FDA approved for people with incontinence and problems. It's not a lot of work with spinal cord injury, but it is something that's has been shown to have some effectiveness as well. And so with each person, we try to see what their hand function is, what their situation is, and we try to work with that.
Excellent. There's been a number of questions on bladder Botox. And one of the first ones said, are there any theories about potential adverse events from long-term use of bladder Botox injection, like increased scar tissue or bladder cancer?
Well, that's a great question. And that was actually a concern of giving Botox repeated injections. And so there was a study done where they actually did biopsies in the people who had had repeated Botox injections for a number of years. And what was actually found was with the repeated Botox injections that those individuals had less scar tissue. Remember that slide on the trabeculation? Well, they had less scar tissue than those who didn't have Botox. The theory is that what happens is the Botox will relax the bladder. It allows good blood flow into the bladder. And so you don't get that scar tissue from having insufficient blood pumping to the bladder muscle. So in that regards, there's not been, it's the reverse. It actually helps with that problem.
Excellent. The next question, we're going to talk about a couple of medications. Are you aware of any proven benefits of taking colloidal silver supplements for bladder health?
I have a few people that use it, and I would say that there's not been any really good studies. And what I usually tell people is we all have our own microbiome, and that's well known. And so what may be very helpful for one person may be not helpful at all. For example, it's interesting, if you look online from Amazon for a probiotic, you'll find one person will say, this is the best thing ever. I'm not having any problems or any infections or anything at all. The next one will say, I didn't notice anything at all. And the next one will say, well, it sometimes works and it sometimes doesn't. And the other one will say, all this does is cause gas and bloating. I hate it. So the point is that for some people, that probiotic was just right for that microbiome and took care of it and changed it. For others, it didn't. So basically, it's if you find that that colloidal helps, then that was probably doing something good to change the microbiome around. But there isn't any universal, okay, everybody take a colloidal and you'll all do great, or vice versa. So that's why it's something, and it's kind of an exciting area of we're learning more and more about microbiomes. Then maybe we'll be able to say, we'll use this probiotic for this microbiome and use this probiotic for that microbiome to keep people from having infections. So that's sort of the answer on that.
Yeah, that's very insightful. Along a similar line, do you recommend D-mannose supplements or mesanamine hiprate or Hiprex for UTI prevention or other bladder health?
Yeah. Same sort of thing. It's the microbiome. And in that regard, the D-mannose and also cranberry, I'll throw that in as well, have been shown to help to keep E. coli bacteria from being able to attach to the bladder wall. So if your microbiome is made up of E. coli and you're getting lots of infections, and studies show, that's the most common one. So that's why there's studies that prove that if you take cranberry and if you're able-bodied woman, you don't get many, you don't maybe not get as many infections because it's working. With spinal cord injury, though, you often have different types of bacteria in the bladder. So you could take all the D-mannose or cranberry you want, and it may not do anything at all. So basically, it won't hurt you at all, but it may not be very effective as well. So as far as the mandelamine, this is a little bit different. Mandelamine is a fairly universal at changing a microbiome. And I have a sort of a story, and I know we don't have a lot of times, but I think Dr. Solinsky's heard the mountain lion story. And I think I'll tell that to you all. What happens is, let's say that you have this mountain lion that's living in the mountain, and it comes down, it loves the snowy area, it comes down to the village, it grabs an animal and runs up, and the farmers shoot at it, like giving these antibiotics back and forth. It's as happy as can be. But if you get that mountain lion and you drop it off in the middle of a Sahara desert, that mountain lion is going to look all around. He's going to say, wait a minute, this is not for me. He'll take off and you'll never see it again. Well, that's kind of what mandelamine does. It changes the pH of the urine. So it turns, the whole environment changes. And by doing that, you'll often find that the microbiome that changes, and people will not have infections because what was causing infections is nowhere to be found anymore. There's still bacteria in there, but it's a different microbiome. So that's something that's very helpful, especially if you don't have these that E. coli type of bacteria, or even if you do and the mannose and things aren't working.
Excellent. I think we'll pivot to a few questions about autonomic dysreflexia. So the first is, can people with SCI below T6 neurologic level of injury experience autonomic dysreflexia?
Well, this is very interesting. And we actually have looked at people, and we monitor everybody with their blood pressure. And we do have sometimes people's blood pressure go up who are below T6. And what I've found is that the blood pressure that's going up is often because they're anxious, or especially, let's say somebody's lying there getting a bladder test, and all of a sudden you start to feel the bladder filling up. Well, that would probably set off a fight and flight, not dysreflexia, but oh my gosh. And the blood pressure starts to go up. And then when you empty the bladder, it goes back down. Well, you could say, oh, that's autonomic dysreflexia. But remember that pattern that I showed you before, if you're below T7, that you're probably not having the true autonomic response. But yes, your blood pressure can go up. And it's interesting that we had a person, and Dr. Solinsky, I think, remembers, who had a high-level tetraplegia. He laid down on the table, and his blood pressure was 140, which often happens when you first get the person on the urodynamics table. And then we said, oh, your blood pressure is 140. Well, that was a little high for him. And he went, really? Got a little bit concerned about that. And then we take it again. So we took it again. We said, oh, your blood pressure is 150. We hadn't done anything, just lying there. Oh my goodness. Well, try it again. And we tried it again. Oh, your blood pressure is 160. And he got more and more concerned, and the blood pressure kept going up and up and up. And so I said, well, you know what? We can't do your test. Your blood pressure is too high. We took another blood pressure and it was back to 130, right? Within 2 minutes of telling him that he didn't have to have his bladder test. So again, that wasn't really autonomic dysreflexia, but it's a C6 injury. And you could sort of say, well, yeah, that blood pressure went up, but he didn't have really a noxious stimuli, but he did have a kind of an emotional type of issue. So the answer to that question is that yes, I think the blood pressures will go up even below T6, but I don't think this is the true physiological autonomic dysreflexic type of response.
Okay, excellent, thank you. There's a few questions about kidney stones and bladder stones. What causes calcification in the kidneys, and is there a need to monitor dietary calcium?
Okay. Well, traditionally for kidney stones, it's been for an able-bodied person, they're called calcium oxalate stones. And that's the most common one. And we used to say calcium oxalate. Okay, well, quit taking calcium and then you won't get kidney stones, especially someone who's getting them. Well, then a number of years ago, it actually, at the American Urology meeting we had, it was the talk of the meeting because somebody found that if you took calcium, you had less calcium oxalate stones. Not overdid it, but just took some calcium because everybody was saying, don't take any calcium. And what it was found out is that when calcium mixed with oxalate in the intestines, that it made a big molecule that wouldn't get through the intestinal wall, and the whole thing just passed right out in the stool. So, and now we actually say, well, you don't, take a little calcium, don't stop altogether. So that's for that type of stone. There's other types of stones that have something like uric acid in them, and they are from a different type of dietary type of thing that will cause them. It's things that have a lot of uric acid. But in the spinal cord patient, we've traditionally felt that it was due to having the bacteria that make the urine get very alkaline, Proteus. And when it gets that way, the crystals come out of the urine and they form stones, calcium phosphate and magnesium ammonium phosphate. They're called struvite stones. Those we didn't have any, the diet doesn't make any difference for, but it's interesting, just very recently we did a review and looked at the stones we were taking out. And a number of people actually have what we call these metabolic instead of the infection stones. And so I think it is worth finding out what kind of stone there is. And then there are definite treatments for many of the ones. For the urease stones, the ones from infections and bacteria, it's mainly just trying to keep the stones out of the bladder and out of the kidneys so that they don't just keep growing and growing.
Excellent. Along those lines, do you recommend any flushing of indwelling catheters with saline or acetic acid or citric acid to try to change that environment?
Well, there's something that we use, it's called renocidin, and it is an acidic solution. And it is very effective at trying to prevent stones, but it is very labor intensive too. And so you do have to flush and use this, a couple times a day. Some people can use it once a day. But also, the most likely cause of having stones is having an indwelling catheter. The most common reason for having an indwelling catheter is because you have a high-level injury. So the risk and concerns of just constantly squirting this renocidin or one of these solutions it's in some people it can set off the autonomic dysreflexia because it is sort of an acidic solution. But it's important to always test it. But if you have a lifestyle where you can have somebody doing the rinsing, you do have to sort of monitor for magnesium and phosphate in the blood just to make sure it's okay. But if we have had very good success with that. But we've also had good success by just more frequent cath changes and doing this as well. So the answer is yes, the flushes are something that's definitely a useful thing to do in certain people, but I don't think it has to be routinely done in just everybody.
Okay. Along those lines, how often should a suprapubic catheter typically be changed, and are there reasons why you would change it at a different rate? I think you kind of started to lead into this.
Yeah. Well, as far as the suprapubic catheters or Foley, either ones, I said before that 30% of people do get stones. It's really interesting. As we learn more about these microbiomes, I think it's that 30% of people must have a microbiome type of bacteria that just likes to make stones. So once we know who those people are, we had somebody years ago who was just coming in every month and they would have stones in their bladder. And the routine is usually, the insurance usually pay for once a month cath changes. But we said, what the heck, we're gonna have it changed every week. So we did that and it was unbelievable. They didn't have any more stones. And it's because it was getting changed frequently enough that the incrustation didn't form. So we have since been carrying that on. And it isn't that we still sometimes when we look in the group of individuals' bladders, we'll see some sand and some material in there, but not the kind of stones where they're getting blocked and going to the emergency room and this sort of thing. So what we do is if somebody has a history of frequent stones, we try to, and the insurance will cover, we then have them get either a weekly or every 2-week cath change. That works really well for a large number of people doing that.
Excellent. The next question, are you still good? I know we're over on time, but
I'm fine. I'm okay. More than happy because I know I gave a detailed talk, so there may be some questions there.
Well, there's over 100 people that have stuck around, so okay. We'll ask a few more.
Okay.
So the next question is, are there any ways to monitor for bladder cancer outside of cystoscopy, going in and looking with the camera?
At this point, it sort of depends on the kind of cancer. The traditional cancer is called transitional cell cancer, and that cancer, I believe there's some different washes and things that are being used. In our spinal cord group, there's a lot of people get what's called squamous cell cancer, and at least for like cell washes and things, those type of cells, the squamous cells, cling much tighter to the bladder wall, and they don't rinse off as well. So it's a little bit harder. So I think traditionally that cystoscopy is still kind of used as the main way to do this. It may be in the future we'll find out that we can do MRI or something else that will also help to pick these up. But at this point, I think the gold standard still is to look in the bladder.
Okay, great. I think the last question I'll ask, can you discuss any efficacy of epidural stimulation devices on either recovery of bladder function for people with spinal cord injury?
Well, there's a lot of work that's just getting started in that area. And so I think it's a little too early to tell, but there's a lot of enthusiasm about it. And I think it's something that will be very exciting to look at in the future for that.
Wanted to thank Dr. Linsenmeyer very much for the hard work you did for the presentation, putting it together. And it was a great presentation. We appreciate it so much. And Dr. Solinsky, thanks for facilitating the question and answer portion. I'd like to thank Diana Pernagati for facilitating the chats. Thank you everyone for attending. Sorry we couldn't get to all your questions, but if you fill out the survey when you exit, or if you copy the link for the survey, we will also send you the survey via email. And that helps us obviously track our success rate on these knowledge in motion lectures, as well as report to our funders and get your input on future knowledge in motion lectures. I hope you all have great holidays and Happy New Year, and we'll be in touch with the next knowledge in motion lecture. Thank you so much.
And I just want to second all of what you just said. You took the words right out of my mouth. I want to thank you for all your help and assistance at getting this all put together and everything as well. I found it very helpful for all the support. So thank you.